Welcome back and thank you for staying with us right here on Morning at NTV. Missed HIV treatment targets have resulted in 3.5 million HIV infections since 2015. Those are only the HIV infections. I've not talked about the AIDS-related deaths, which are about 820,000. We have lost 820,000 people between a space of only 5 years and the missed targets. So here we are in 2020, and COVID-19 has caused some major disruptions. Major is the key word. Disruptions. Remember, since 2019 and now, we've registered new infections, 1.7 million new HIV infections. Since 2019, we've lost 690,000 people to AIDS-related complications. So how has COVID-19 complicated the HIV treatment procedures or targets in that regard? The Joint United Nations Program on HIV and AIDS says 2020 is going to be harder to meet the targets. And they say if we do not do anything about it, we might regress for over 10 years and go back to the global targets of 2008. Those mortality rates, I think you remember very well, in 2008 when HIV infections were rife. But then there's some good news according to the United Nations report. They contend that sub-Saharan Africa has seen a reduction in HIV infections, that is by 38%. However, in Central Europe, in Asia, the situation is far worse, 72% increase in HIV infections. Right here in Uganda, what could the numbers be? Dr. Nelson Musoba is going to be telling us. He's the Director General of Uganda AIDS Commission. A very good morning, Doctor, and thank you for joining us.
Good morning. Thank you for having me.
The report, I think you could sense in my words, is really worrying. It worried me. I spent hours last night going through the report time and again just to try to see, is there hope? And I realized in sub-Saharan Africa, we are doing a little bit okay, especially Eastern Africa, which is 38%, but particularly Uganda. Help us understand. Have we been regressing or improving as far as meeting HIV targets are concerned? And do you think we might hit the 1990 target by at least 2020 ending?
Now, thank you for that question. For Uganda, indeed, we've made some progress, slightly better than the global average. For instance, our target was to reduce new HIV infections by 75% by 2020. Now, when we just did the analysis of our results, we've only been able to reduce new HIV infections by 43%, compared to the global average of 38. And of course, in 2016, when the heads of state at the United Nations General Assembly set the 90-90-90 targets, meaning that 90% of people who are HIV positive test and know their status, and 90% of those who are who know that they're HIV positive start on treatment, and 90% of those who start on treatment adhere so that they achieve viral suppression.
Yes.
Now, for Uganda, for the first 90 of people who are HIV positive testing, we are at 92% before the COVID.
That is amazing.
But for the second 90, we are at 86.
That is people on HIV treatment.
Yeah, on HIV treatment. And out of those, we are on 78% for those who are adhering and taking their medication. Of course, as you've indicated, over the last 3 months, we've had major disruptions. During the lockdown, people were unable to, not everyone was able to access their medications. You know, they ran out of refills, the viral loads went up. The lockdown itself had vulnerabilities, and because of those vulnerabilities, people are forced to take on desperate measures. So we are likely to see a rise in new HIV infections when we do our analysis at the end of this year. So we are close to achieving targets for 2020, but not yet there. And given the COVID disruptions, yes, we are likely to see a reversal in these indicators.
Dr. Nelson, how big of a threat is COVID-19 to HIV treatment targets? According to the Joint United Nations Program on HIV and AIDS report, they contend that if COVID-19 persists with the lockdown, with the curfews and all for the next 6 months, we might lose 500,000 people. Dr. Nelson, in Uganda's perspective, how are we looking?
Indeed, in Uganda, 2 months ago, we did, working with the UN AIDS in Uganda and the people living with HIV, we did a quick rapid assessment to just see what is the situation with our own people. And we found that among the households that were assessed, up to 72% of those had people living with HIV. And 68% had refills that were less than 3 months. Currently, if you're stable and you're on treatment, you do not need to go to the health facility every time. But not everyone who needed to have sufficient refills had them. And therefore, it meant, and yet you needed permission, to go to the health facility, you needed transport, this wasn't available, there are issues of stigma. So that really disrupted access to medications and HIV services. As government, we tried to put measures in place to make sure that this group was prioritized. Of course, food was an issue. You need food for you to be on ARV medication. You can't take them without food. These very groups are the vulnerable ones. They have difficulty accessing food. It meant that, they were issues and they did not take their medications as they are supposed to. So we are likely to see a major disruption. As we speak, by end of 2019, we had done an assessment, and we stood at 23,000 AIDS-related deaths during the whole year. Now, we think this year that might be reversed. For new HIV infections for 2019, when we did the assessment, we had 51,000 new infections, less by 2,000 from the previous year. We again think this might be reversed because of what we've seen over the last 3 months. So indeed, if this situation continues for another 6 months, we will definitely see a reversal in the gains that we've made.
A reversal in the gains. Are we also talking about an increase in new HIV infections?
Yes, it is. We are likely to see an increase in new HIV infections because because of the underlying vulnerabilities, the people at the margins. You saw, the president was appealing to the young people and saying, keep away from the truck drivers but these young people are trying to go there because they are looking for a living. They are having no food. They are trying to get some income. So we are likely to see a rise in new infections because of, these vulnerabilities during the COVID-19.
Of course, Dr. Nelson, out of the 38 million people living with HIV and AIDS, 12.6% of those people did not have access at all to antiretroviral or HIV services. In the case of Uganda, what are the numbers in Uganda, and what is government doing, especially Uganda AIDS Commission, to expand access to antiretroviral services?
For Uganda's case, we've had a fairly rapid, enrollment of people living with HIV.
Right.
Currently, we estimate we have about 1.4 million people living with HIV, and out of those, 1.2 million are on antiretroviral therapy. So we have approximately 200,000 people out there. Some of them know that they're HIV positive, but they are yet to make a decision to start on treatment. Some do not know. So the risk with the 200,000 is that this infection is being spread to those who are HIV negative. So we've done well in terms of enrollment, but we need to do more. We need to search for those who are not yet on treatment. And that is where, as the strategy that we've adopted as government, is to ensure that the responsibility just goes beyond Uganda AIDS Commission, beyond the Ministry of Health. Everyone takes individual responsibility as a person to know your HIV status, to know the HIV status of, urge those who are close to you to go and test, the communities, the people you live with, but especially those at risk to adopt, less risk behaviors. Some of the risk behaviors include having multiple sexual partners whose HIV status you do not know. And and if you must, have sex with somebody whose HIV status you don't know, then you should have protected sex. So a number of interventions, from prevention to enrolling HIV positive people on medication, to using, interventions like condom use. We know that circumcision is protective for men. They can take this on. And then the marginalized groups, ensuring that they can access treatment and services for HIV as much as possible.
It seems people in the city center and people in the cities, urban areas, have some kind of access to antiretroviral services or HIV treatment. But what about the people in the far-flung areas, the rural areas? What are you doing to reach them? And what is the magnitude, the variations between urban and rural? Are people in the rural areas more infected with HIV than the urban dwellers? What are the numbers?
No, what we've seen actually is that the HIV prevalence in the urban areas is higher than in the rural areas. And largely because within the urban areas, you've got, again, the disparities. You've got people within the suburban areas, you know, who, again, do not have access to services. You can be in Kampala, but you'll be in an area that makes it difficult for you to go to the health facility. But also, you might belong to a certain population group that is marginalized. If you're engaged in sex work, if you're a man who is having, people like men having sex with men, those, because they are stigmatized, they can't easily access services. So we see infections rising higher amongst those groups than the general population. In the rural places, there could be issues of access, but currently HIV services can be accessed up to the health center 3s, and the medications are there, the health workers have been trained. So even when you are in the rural area, it is possible to access HIV services, although of course when you are talking about the second line or third line treatment, then you'll have to find those in the higher level facilities.
Before we get into the conversation centered around stigma and discrimination, let's first talk about the key populations. Let's identify those key populations that are actually having the highest number of HIV infections. Now, according to the UNAIDS report, they contend that 62% of the new infections are from a small group of people. The gay people that you talked about, men sleeping with other men for sex. You also have young women dealing in sex work, the sex workers, and you also have the prison. There are so many HIV infections in the prison areas. And then the report contends that this is a small population, yet they make up 62% of the new infections. How did this come about, Dr. Nelson? And what are the numbers right here in Uganda?
Well, this comes about because for some of those population groups in our countries, especially like Uganda, it is illegal to be engaged in what they're engaged in. Sex work is not legal here.
It's criminalized.
It's criminalized. You know, men having sex with men is not legal here. It's criminal. So that means that
I think the statistics were largely based on Central Europe and Asia.
Yes.
But then in the case of Uganda, which are the key populations that we are looking at where these new HIV infections are coming from?
In Uganda, the key populations are commercial sex work.
Yes.
We are also looking at men who are having sex with men. We are looking at the armed forces, you know, because of the nature of their work and you know, the way they move from place to place. It's difficult for them to, you know, access services, but also, you know, test and continue to have treatment. People in prisons, you know, are also among those at risk. And then we are beginning to see young adolescent girls, also being, you know, 3 times at a higher risk than their male counterparts.
That's between 15 and 24.
Yeah, between 15 and 24. And when we look at the key populations in Uganda, again, we see the HIV prevalence being much higher, as high as, you know, from 15% to up to 37% higher than in the normal population, because the average in the normal population is 6.2%. So the risk, like you've said, the group is very small, but the risk is much higher than in the normal population.
Are you targeting these groups as Uganda AIDS Commission? Because I've noticed you're focusing on the majority of the people who are not engaging in risky behavior. And there's this small cohort, this small group of people that is actually maximizing the number of new infections. Are you reaching out to the prisons, to the UPDF, the army, the officers, so that you talk to them?
Yes, the armed forces actually have very robust HIV programs. The UPDF was among the first institutions in Uganda to enroll their people in antiretroviral therapy. So they have a wide program, a very good program. Uganda Prisons has a very robust program. Of course, there are things that they can't implement because of our laws, but, you know, they make sure that every prisoner who comes in, they are tested for HIV, and those who are found HIV positive are immediately enrolled on treatment. So, and then we've had to make sure that, first of all, the public health law doesn't have the discrimination. You know, you'll be given health services irrespective of who you are and what you do. So that helps in a way. It is really now working on the attitudes of the health workers, ensuring that they do not, you know, discriminate those who are coming for services. But also the Ministry of Health has ensured that health facilities are being flexible. They are open for some of those population groups. They are, instead of staying to wait for them to come, they are going out, you know, to take those services to them. Men, for instance. Men are a group, you know, they don't have a very good health-seeking behavior. And instead of waiting for them to come to the health facility, there are innovations, you know, to take services, HIV testing services to the workplace, opening for long hours, health workers having more positive attitudes towards these groups. We think this should help improve, you know, the enrollment, the people who are coming for testing, but also ultimately a reduction in new HIV infections.
Well, of course, I've seen a country that did so well. That is Eswatini. Eswatini in 2019 had very, very high HIV infections, 27%. But guess what? In 2020, they managed to beat the whole HIV target by 95, 95, 95. How was that possible? How did they move from 20%, 27% all the way to 95, 95, 95? And they are also looking at 100, 100, 100 by the end of 2020. How did they do it, and how can Uganda borrow a leaf?
It is largely, you know, taking the approach away from the health facilities, adopting, you know, a community approach, ensuring that services are based at household level. You're going out into the communities and not necessarily sitting back and waiting for people to come for services, reducing stigma and discrimination as much as possible, because sometimes people are worried and say, if I become HIV positive, well, what will happen? Will my family discriminate against me? Will my spouse, you know, send me away because I've just turned HIV positive? So ensuring that the levels of stigma and discrimination are reduced, reduction in gender-based violence, but mainly also taking on, you know, a community approach. The other factor that we have to do is ensuring that we mobilize more domestic resources. Currently, we rely quite significantly on foreign resources.
That's right.
And yet, every time, you know, the global priorities change, you know, these resources shift with those changes. If you have your own local resources, then you fund where you think the need is. Like now, we know for Uganda, HIV prevention is a major need, you know, ensuring that the young people in schools get the messaging, they can access, you know, the testing services, they can keep themselves safe. But, you know, the resources now are largely geared towards antiretroviral therapy, which is a deserving area. But in addition to this, it needs to move hand in hand with HIV prevention as well. And once you have the HIV combination approach, then we can be able to achieve the reach where Eswatini is. I'm
being tempted, but I do not want to get into the stigma and discrimination conversation before I exhaust the issue of the women and the girls.
Yes.
Now, according to that UNAIDS report, 59% of young women, actually women and young girls, are actually grappling with new HIV infections. The biggest number are the women and the young girls. That is 59%. Now, out of that 59%, the young girls make up 24% of that whole number. Now, yesterday I was reading the news from Bunyoro region, and they were saying young girls are getting pregnant left, right, and center. Young girls between 15 and 24. What is happening, Dr. Nelson? What is happening to the young girls?
It is a question of information. You know, when again in Uganda we did a study of the seroprevalence survey that was released by the Ministry of Health, we found that close to half the number of young people surveyed did not have what we call comprehensive knowledge for HIV. If, for instance, they ask a set of 5 questions and say, if you bought tomatoes from a grocery vendor who has HIV, you will get HIV positive. And you can see half of them did not know the right answer. Now, if you do not know how HIV is transmitted, you will not know how to protect yourself. So,
are you telling me we still have teenagers between 15 and 24 who do not know how HIV is? Wow.
They do not know, because if you
How so? Sexuality education is primary for around 10 years.
It is, I think we need to lay more emphasis on it, because I'm sure you've heard young girls who say that I would rather have HIV than become pregnant.
I've heard that before.
Because pregnancy is visible. But that is, you know that HIV is a lifelong, it has no cure.
But tell them it's a lie. Please tell them it's a lie right now.
Definitely. The young people out there, I would like you to know that there is no cure for HIV. Although there is treatment, it only makes you better, but you'll have to take it for life. And that's not something you'd like to have. So don't say that you'd rather have HIV rather than pregnancy. You need to avoid, you you shouldn't engage in risk sex because it has consequences. And those consequences include becoming pregnant, getting HIV, and other sexually transmitted diseases. Yes.
Okay, let's continue, Dr. Nelson. Besides a lack of knowledge on how HIV is transmitted, what makes these young girls more vulnerable to HIV transmission?
The economic situation.
Right.
You know, there are those underlying factors. If a young girl, you know, you have a household that has 7 or 10 children, putting a meal on the table is a problem. When they get to adolescence, they start having menstrual periods. They can't afford menstrual pads. They do not have books to stay in school. So that pushes them to the margins. And if somebody is offering some little money to them, it will force them, you know, into engaging into sexual relationships. So economic empowerment is key in reduction of HIV infections. School is also key because school is a safe space. So if we keep these young people, especially the young girls in school, we are likely to see them, you know, protected from HIV infection. So economic empowerment, giving them information, keeping them in school, we will protect our young people from getting, you know, more infections. So if we target those interventions.
All right, let's go back to the UN AIDS report, which also indicates that there's been increase in HIV infections simply because of COVID-19, not really because of COVID-19 as a pandemic, but because we've shifted resources, HIV resources, to combat COVID-19. Has that been the case in Uganda? Have we shifted resources from HIV treatment centers to actually combat COVID-19? And how has that affected your operations as Uganda AIDS Commission?
In some of the areas, you know, like the resources available for antiretroviral therapy and HIV testing have not necessarily reduced. But the resources, for instance, Uganda AIDS Commission had asked Parliament for additional funding for us to ensure that we reach out to the coordination agencies. One of the ways we are making sure that Uganda makes a dent on HIV is to make sure that all institutions, both government and non-government, integrate HIV in the things that they do. They have an HIV focal person, they have a committee, they have a dedicated budget. But we need to have that done by following up with these institutions, supporting them to have plans, ensuring that they understand what they are doing. But we need a budget to be able to do that. Now, we had asked Parliament to give us additional funding, and that hasn't come because the resources were taken to COVID. So in a way, resources for prevention, for coordination, have not, you know, increased to the level that we had desired because of that. And also, the funding, we would need additional funding to put all the people on antiretroviral therapy. That didn't necessarily reduce, but we have the 200,000 people that are out there that we need to look for and also put on treatment.
Maybe if they understood the effect that funding has had on your operations, they would give you the money. Please help them understand how the cutting of funding has affected your operations.
As one of when the president launched the Presidential Fast Track Initiative in 2017, he emphasized 5 points. And one of the 5 points is to have sustainable domestic financing. And as Uganda AIDS Commission, we appeal to Parliament and government to increase our budget so that, you know, we can coordinate our government sectors and also the non-public sectors to ensure that they integrate HIV into all the activities. They have functional committees, they have workplace policies, they protect their employees, but also the communities with whom they are interacting to ensure that they remain HIV positive, they take on safer behaviors. And we can only do that if we have a budget to be able to run the activities.
Amazing. I think you sent the message home, Dr. Nelson.
Thank you.
So let's talk about stigma and discrimination coupled by some of the inequalities that are impeding the fight against HIV and AIDS. Ending it, what are the barriers?
The barriers is that we have what is known as internal stigma, and that's where an individual feels that what the public perceives of them. So one, it will keep people away from coming to seek services, especially we talked about the men, because you say, how will people see me lining up, you know, going for services, but also if I'm HIV positive, then I will be perceived to be weaker, I won't be able to do my work. So we have actually stories of men who wait for their spouses to go and test and then deduce that they may also be positive, and they start, you know, encroaching on the spouse's medication.
Right.
Not only are you endangering the life of your spouse, but also yourself.
So you're just assuming since she has HIV and AIDS, I'm also
having HIV, which is not true. So that is largely internal stigma. But there's also external stigma where actually other people are saying this person is positive, you know, and they start discriminating them. It can be at family level. It has been reported in schools, you know, where teachers discriminate against children who are HIV positive. It means those little ones will not take their medication. Sometimes they are discriminated against by fellow learners, you know, put in a different corner. But now we have knowledge that HIV, how it is transmitted, you know, that it's not transmitted through shaking hands, through hugging a person. And it is largely lack of information that leads to stigma and discrimination.
Does viral suppression actually reduce the chances of someone infecting another with HIV and AIDS?
It does. It does reduce because we have what we call, once you take your medication consistently and well, it has two major advantages. One, it makes you a normal person, you live well, you become productive. But also two, it reduces the chances of you transmitting to your sexual partner. In fact, it's known as undetectable is equivalent to untransmissible. It means if your viral load, the virus can't be, it doesn't mean you're HIV negative, but if the virus is not detectable in blood, then you will not give it to your partner. And that is a very positive thing. But it has another element in the reduction of stigma. If you're taking your medication, you look well, because the earlier HIV was very visible. People would lose weight, they would have skin infection, I mean, you know, diseases, and they would not look nice to the eye. But now, a person living with HIV looks like you and me, that the way we are seated here. So that, in a way, can reduce stigma, and people will not, you know, just be able to look at someone and say, you can see so and how they look. So it has really those two major advantages.
And you can also have a spouse who is AIDS, HIV positive, but while you're still negative.
Yes, that's true. We call that discordance. Discordance arises, you may come together when both of you are negative and one becomes positive. It means, you know, you're not being, and that's why the ABC still applies. You know, being faithful, that is the B. So if one of them probably went out of the relationship, they can get HIV. But the two needs to make sure that the HIV negative partner remains negative, because if one of you is negative and the other one is positive, then you'll always be there to support the other during times when they are not well, when you need to go and get their medications refilled, when, you know, you have to support them either economically or otherwise. But if you do not take precautions and measures, studies show, you know, that a very large proportion of those seroconvert and become positive. So if you're a discordant couple, the HIV positive partner must take their treatment faithfully so that the viral load is undetectable. It means they will not infect their negative partner. But also, two, they need to engage in protected sex so that, again, you do not transmit to their partner. But if they are of reproductive age, should they want to have a baby, they can speak with the health workers to advise them how they can do that. And it's possible to have an HIV negative baby even when the parents are HIV positive.
And what about the widespread inequalities, the social inequalities, in that people in urban areas have equal access to antiretroviral services, whereas people in the rural areas are grappling to access these services? Because right now you have UNAIDS talking about the AIDS issue as a human rights issue, and it's calling on the countries all over the world to enact laws that could protect people as a human rights issue. What do you have to say about that? Yes, the social inequalities.
The social inequalities remain an issue. You know, access to services. We can see that in the urban areas, the higher level health facilities, the more qualified health workers, because they are looking for services, they tend to aggregate in the urban areas. But what government has done is to ensure that the health services, the HIV services can be accessed across, because a health center 3 is supposed to be at the sub-county level. And within a health center 3, you should be able to, you know, provide antiretroviral therapy. The health workers there are trained to do that. If they need a more advanced, you know, consultation, they can refer once in a while. But the largest proportion of services should be accessed up to the sub-county level. So there are those efforts from government to ensure that these services are accessed at the lowest level possible. We cannot avoid having certain services, like the viral load, count, and some of the more complex ones, they are still at a higher level, but the samples can be transported without having to make the patients move, or the clients move all the way from the communities, looking for these services in the urban areas.
And of course, Dr. Nelson, according to the UNAIDS report, if we do not do anything to avert the COVID-19 pandemic and this lockdown stretches to the next 6 months or so, we might regress to the 2008 mortality levels of HIV and AIDS. Is this true?
It is possible to regress if we relax, and that is why.
But 2008 would be worse.
It is worse because in 2008 we are talking about annual new HIV infections for Uganda of about 140,000 every year. Currently we are saying we are at 51,000. So you don't want to go there. The AIDS-related
triple.
Yeah, triple. The AIDS-related deaths back then were about 60,000 deaths every year. We are at 23,000 now. You do not again want to go back to those levels because the numbers are just too big. It would affect our economy. It would affect the way we do business generally as a country, because institutions, factories, they are relying on these young people, to be able to do what they are doing, and they need to remain healthy. They need to remain energetic. It is not a risk that as a country we are just willing to take. So,
well, what were we doing wrong in 2008 to lead to these many levels of HIV? And what are some of the remnants of the same mistakes that we are doing right now?
First of all, our early HIV epidemic response largely relied on prevention, in the early 90s and early 2000. Then we had the antiretroviral therapy coming. Then we saw an improvement between up to 2005. After that, we shifted focus and kind of became complacent. I think when people started taking ARVs and got excited, then by 2011 we saw the infections had gone up. So after that, what we did was to ensure that we provide equal focus on HIV prevention as well as treatment. That while you're enrolling people in treatment, we should also emphasize that take precautionary measures, ensure that you engage in safe sex, young people, let them circumcise, using condoms and all the others. So a combination of both treatment and prevention is what made us see the success that we are doing now, and we need to emphasize that. We need to emphasize the prevention messages, make sure that young people are taking precautions. They know that HIV is still out there, and those who are becoming HIV positive, they come and test, they enroll on treatment, they take their medication as they are supposed to, so that the viral load comes down. So that's what we call the HIV combination prevention as well as treatment strategy.
Do you see the same mistakes in 2020 being made?
That's why we are talking now. We wouldn't want that to happen. We wouldn't want us to have a reversal and go back. And as government, we are emphasizing, in fact, the whole of yesterday and today, Uganda AIDS Commission is having meetings with different ministries and agencies, again reviewing what is it that we've done over the last 1 year, what are we going to do differently, and we are emphasizing the message of prevention, while the Ministry of Health still continues to focus on ensuring that those who need services are coming to the health facilities, they are testing. Those who are positive are accessing treatment. Those who are negative are again, given packages of ensuring that they remain HIV negative.
And of course, we are talking about achieving the 90-90-90 targets by 2030. Is this possible, Dr. Nelson?
2030 is, we've looked at, because the ambition is to end AIDS as a public health threat by 2030.
Is that possible with the threat of COVID-19 and all the disruptions?
We would have to work harder than we are doing now. We need to triple our efforts.
What needs to be done?
We need to, make sure that we heighten the information campaign.
Okay.
We need to include, we need to increase resources that are available, especially for HIV prevention. And most of those would like to mobilize domestic resources. We'd like the private sector, to come on board, do as much, both for their own employees, but also the communities that they're interacting with. We also appeal to the leadership, that leaders at all levels should take on, HIV message sensitization as we go into the campaigns. Let every leader include HIV in the information, packages that they are giving to the population, because I'm sure leaders would like to lead a population that is healthy. And as they talk about COVID, HIV is one of the things that they should include in the messaging, telling the people that HIV is still here, that it has no cure, there is no vaccine, the treatment can only take you for a while, and they need to take precaution. Yes.
Of course, Dr. Nelson, we've been talking about the mortality rate during COVID-19. You've not given us the numbers. How many people have we lost as a result of COVID-19? Poor access to their antiretroviral services, and they had to succumb to HIV. Because I was telling you about the 6-month window that will lead to 500,000 deaths. But then according to the UN AIDS report, they also contain that a simple 20% disruption will lead to 110,000 deaths globally. In Uganda here, what are we looking at? What are the numbers?
We don't have the final results yet. We are still, usually we compute data at the end of every calendar year. So we will work through that and have that information by December. So I can't tell you now that these are the numbers who have died because of COVID. What we know is that we are likely to see a rise in these numbers because of this period that we've experienced and the challenges in accessing services. But that information, the exact numbers will become available later on.
Okay, Dr. Nelson, your final message to the viewer right there, and we wrap up.
I would like to appeal to Ugandans and remind them that even as we go through the COVID-19 period, HIV and AIDS is still here. We've made lots of progress because of your vigilancy, but we wouldn't want you to relax. There is no cure, although there is treatment. So for those of you who need to know, go and test and know your HIV status. If you're found HIV positive, there is treatment available. Go to the nearest health worker. They will advise you on what to do. Do not discriminate those who are HIV positive. We know that those who are positive and on treatment can live a productive life if they are taking their treatment, and they can do everything that those of you who are HIV negative can do. So let's avoid discrimination. Let's treat others the way we would like to be treated. But also leaders, I'm appealing to the leaders to ensure that they integrate HIV prevention messages as they are communicating to the population, even during the period of campaigns. Thank you.
Dr. Nelson, right there, Musoba, the Director General of Uganda AIDS Commission. We've been talking about the high HIV prevalence rates as a result of COVID-19 and poor access to antiretroviral services and other HIV services. The Joint United Nations Program on HIV and AIDS is not only clamoring for HIV and AIDS, they're also talking about a people's vaccine for COVID-19. Guess what? 150 countries have already signed an agreement so that we can have a cheaper drug, patent-free, and for everyone. No such thing as America first or Japan first, but everyone, because they realize if we do not do away with COVID-19, at some point, HIV infections will rise because people will have little or no access to HIV services as they continue to grapple with lockdowns, with curfews, and other disruptions to the transport system. My name is Romeo Busiku. Let's take a short break. We'll be right back with more information right here on Morning at NTV.